Hi, welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor of JAMA Network Open.
And I'm Mike Berkowitz. I'm the electronic editor for JAMA and the JAMA Network.
All right, so jumping right in, our first paper today is the association of coronary artery calcium with long-term cause-specific mortality among young adults. And we've got first author, Dr. Michael Miedema here. Welcome.
Thanks for having me.
So why don't you introduce yourself, tell us a bit about the study.
Yeah, my name is Mike Miedema. I'm the Director of Cardiovascular Prevention at the Minneapolis Heart Institute. And so we really wanted to look at the impact of potentially using coronary calcium scoring in younger adults. We have a lot of good research showing that in middle-aged adults, it potentially can lead to changes in clinical decision-making, mainly to the decisions about starting preventive medications. But for younger adults, there's less data. And really, most of the data before has come from the general population, cohorts like cardia, which are meant to be, healthy, asymptomatic people. And really, over time, for calcium scoring, I think some of the initial controversy was about using it as a screening tool, meaning it was kind of broadly applied to the whole population. And over time, we've gotten smarter in using it mainly as a tool to help aid clinical decisions for people that have questions about their risk. And that's really more of a unique population. That's a smaller subset of the population. And so we wanted to look at the impact of calcium scoring in people with clinical indications for calcium scoring. And so mainly in younger adults, that'd be people with high cholesterol and people with family histories of coronary heart disease. And so we use data from our Calcium Consortium, which is a multi-center cohort that we have that has 66,000 people that have had calcium scores, and then we have mortality over time. We have 12-year follow-up on average. And so we took our people aged 30 to 49, which was over 22,000 people, and we looked at their baseline calcium scores and the prevalence of coronary calcium, and then we looked at mortality from coronary heart disease and cardiovascular disease and all-cause mortality over time.
Nice.
And basically,
oh, go ahead, sorry.
Yeah, and basically what we found is that 34% of people undergoing a scan had some evidence of plaque. So 1 in 3 individuals, which the previous studies from the more general populations showed it to be around 1 in 10 or 1 in 12. So in a group of people that have risk factors or have reasons to think about getting a calcium score, you're much more likely to find plaque. And then subsequently, the people that had plaque had significantly elevated rates of death from heart disease, death from cardiovascular disease, and all-cause mortality. And then including in a multivariable analysis, even if we adjusted for traditional risk factors, the risk was still significantly elevated.
Okay, interesting. So can you quantify how much of a accuracy advantage is there, or incremental advantage is there over traditional risk factors?
Well, we know in middle-aged populations that your calcium score trumps traditional risk factors. People that have no traditional risk factors and have a high calcium score are clearly at high risk, and people with 3 or 4 traditional risk factors and a calcium score of 0 are at low risk. So it does a good job. It definitely can increase discrimination in your ability to predict who's going to have a heart attack and who isn't.
Yeah, and so Seth and I have talked about this before. I'm used to seeing kind of reclassification analyses where you see, you add CAC scoring to the traditional Framingham risk factors and see what gain in accuracy you get in reassigning patients to low, intermediate, or high risk. So do you have that in these data?
Nope, that doesn't quite fit here, because if you take a group of young individuals, they're almost universally at low risk. So if you put their risk into the pooled cohorts equation, that 10-year risk calculator, the average risk in our population was about 2%, which would all put them at low risk. Okay. And that's one of the issues in addressing younger adults, is that they all come out as low risk, and so you don't quite know what to do. Whereas with coronary calcium scoring, we know the people that are at low cardiovascular risk but have a high calcium score, they're clearly at elevated risk moving forward.
Right, but that sounds like an argument for screening, that there are traditional tools for risk classifying patients aren't accurate enough. We need to kind of order the technology. The way I was trained, which is already a little while ago, is that this technology is good for that 5 to 10%, or maybe 2.5 to 10%, that intermediate risk where you're not sure whether to withhold treatment or go ahead with a lipid-lowering drug. So I kind of want you to kind of follow that line and explain a little better if you can.
Right, and so again, for middle-aged adults, a lot of them end up in that intermediate risk group where we don't quite know what to do. Right. For younger adults, they almost virtually all end up in the low-risk group. And so then by theory, we should say, well, we should leave all these people alone. Yet we know that a decent portion of our heart attacks occur in younger individuals. And so for younger adults, we do want a better way to risk stratify. And so again, if you just look at the general population, using calcium scoring in all young low-risk adults doesn't make a lot of sense. But if you have borderline cholesterol, or if you have this family history, that's a group that consider undergoing the calcium score.
Got it.
Yeah. Okay. And I think the figure, is pretty interesting to me. In the top part here, it just shows just what the rates of the coronary artery calcium are, and even the only or less than 80% of the patients in their 30s had 0 scores, and then again less than 20% in had the 1 to 100, which is I guess the intermediate score. And that's kind of depressing. That
It is. Well, I mean, we know that the process of building up atherosclerotic plaque is a lifelong process.
Right.
It starts really early in life, and so I think the previous thinking, and even I would have thought myself before we did this paper, that for most young adults it's probably not worth checking because you're not going to find any. And again, that's what the take-home was from some of these earlier papers that looked at a generally healthy population, that in general it probably doesn't have that much utility. What we showed is that for this certain subgroup of people, these people who have risk and have concerns, you find it more commonly than what you think.
Yeah, that's interesting. It's funny because I kind of have my clinical experience is the opposite from my perspective. I'm an ER doc, so for me, it's trying to find patients who I can identify as low risk and who don't need more testing. And one of the challenges for me is we have, I'd say, a small availability of coronary CT in RED. And what's frustrating is that most of the patients who I think are low enough risk to actually have a negative study are so low risk that I don't need to do the scan. And if I think they actually need it, then the chances of them having some sort of positive finding is high enough that we might as well just do the formal stress test.
I think this for calcium scoring, in the outpatient world, especially when we're talking about shared decision making, I think some of the kind of critiques of calcium scoring in the past is that if you kind of approach it from a paternalistic standpoint, you mandate somebody to get a calcium score, is that really the right thing to do when we don't quite know as much about it as we'd like? I think in the more modern times, we've really approached this from, if you're at elevated lifetime risk and you're 35 or 40, I think the options are to focus on lifestyle, which is a very reasonable option, to focus on lifestyle and consider a moderate intensity statin. Or if you're unsure about your risk, focus on lifestyle and get the calcium score. I think to offer all three of those to the patient is pretty reasonable. To withhold the idea, we know that the findings of plaque carry significant weight. And, and the people in our study, if they had a calcium score of 100 or more, which was a little bit less than 10%, so it wasn't that common, but those people had 10 times the rate of death from coronary heart disease over follow-up. So if you extrapolate that out to a longer term, these people are young, we care about their next 30, 40 years of life. That's definitely a significant increase in risk.
Now, and some people distinguish between 0 and non-zero CAC scores, coronary artery calcium scores. Your data seem to suggest 0 to 100 is kind of a safer place to be. Do you agree with that clinically, or
not necessarily? Because it's a safer place to be for the next decade if you're 35, which we care again about the next 30 to 40 years. And so, to me, the main value of the test is the 0 and the non-zero. Once you have some plaque, it's going to progress with time, and higher scores do correlate with higher risk, but only incrementally so. In terms of decision making, in terms of moving the needle one way or the other to say we're going to change what we're going to do, I think the 0 and the non-zero is probably the main finding.
Okay. And I'm curious because I've seen coronary CTs done a couple different ways. Do you have any data on the rate of kind of incidental findings? Are you coned down really far and just looking at the heart? Or are you finding lung nodules and things like that?
Yeah, so we do have some incidental findings. The main ones would be ascending aortic aneurysms, which are often mild, and then we have to follow them with imaging, and then pulmonary nodules. We do try and limit the scan field as much as possible to exclude some of those things, but we always do get a measurement of the ascending aorta, and we do get some lung nodules on occasion. So there is the downside. The radiation dose is around the dose of a mammogram. We're about at a half a millisievert in most places now, and the cost is about $99 in most places. So there is some downside, and that should be talked about with the patient.
Yeah.
And this is going a little bit off the reservation for this particular paper, but there are other emerging coronary risk factors, high sensitivity CRP, for example. I wonder whether you could comment on whether it's really all about coronary artery calcium or whether there are other things that people can do to risk stratify.
So I think there's two different components to that. There clearly are other risk factors that are involved other than just coronary calcium. But in terms of a test that can actually move your absolute risk enough to where you do something differently, I think the calcium score is the best thing we have. HSCRP is a great example where it's clearly part of the physiologic process of the pathophysiology of coronary artery disease. That makes it super interesting. But as a clinical tool to assess risk, it's not that powerful of a predictor. There's a lot of people with normal CRPs that don't ever have events, and there's a lot of people with elevated CRPs that, the other way around. There's a lot of people with normal CRPs who have events, and there's a lot of people with elevated CRPs who never have events. And so, as a clinical tool, I tend not to use that as much.
Okay. And where are we as far as implementation? Are people already doing this? Should we be doing it? I'm 37. I need to get one of these.
So, the cholesterol guidelines.
Awesome.
The cholesterol guidelines recently gave it a recommendation that for intermediate risk people, it's a tool you can consider if you're unsure about your level of risk, and if you're unsure that you want to take a statin. And most of our patients don't want to take statins, and so we use it a fair amount. For younger individuals, I think the only group you really want to consider is those people with strong family histories that you really want to get a better assessment of their risk.
Okay, interesting.
Great.
All right. Any other debates in the field on this?
No, I don't think so.
Okay.
It's buttoned down.
Great.
Well, great. I learned a lot from talking to you.
Yep. Thanks for
Excellent.
joining us.
All right, thank you.
Thanks for your paper, and thanks for sending it to JAMA Network Open.
Thank you.
Great. Take care.
Okay.
You too.
What do we have next?
All right, next we have, this is an interesting one for me. It's the association of serum albumin with apnea in infants with bronchiolitis, a secondary analysis of data from the Mark 35 study by Mansbach and colleagues.
And why is this interesting to you in particular?
So bronchiolitis, which is basically a respiratory disease of kids, it's pretty common. Most kids do pretty much fine. A lot of times it's somewhere in the spectrum of a pretty bad cold to a flu-like illness for kids. A small fraction of these kids get pretty sick, need to stay in the hospital. And what's terrifying is that a tiny fraction of these kids end up having apnea, where they just plain stop breathing without any real predictor stuff. And that's terrifying. It's kind of like myocarditis, where most people do fine. Every now and then someone suddenly just, stops basic life functioning.
Right. And so this study looked at serum albumin.
Mm-hmm.
I'm tempted to say a marker, but that's not really fair. It's probably a risk factor in terms of a variable in a logistic regression equation that's associated with the outcome.
Right. Yep. So basically what they did is they took 1,000 infants from 17 U.S. hospitals, 2011 to 2014, excluded the preemies before 32 weeks, and kids with pre-existing heart or lung disease. And collected albumin in the first 24 hours, did all sorts of other stuff like check for RSV, and then tracked to see what happened, and basically found a small amount, I think it was 25 out of these 1,000 kids had apnea in the hospital. Of the kids with a normal albumin, 0.5% had apnea, and of kids with a low albumin level, so less than 3.8, 5.7% had apnea. And then there was the highest risk group was kids who were both low weight and low albumin level, and who are age under a month, had a nearly 15% apnea rate, which is pretty terrifying.
That is pretty terrifying. But is albumin, what's its clinical significance? I mean, is it a marker for physiologic distress in some way that if you had a low hematocrit, for example, and I'm making that up, you would find comparable kinds of associations?
Yeah, maybe. The answer is we don't know. There's a nice little paragraph in the paper where they kind of walk through some of the different pathways that could potentially explain it. Maybe something to do with nutrition, maybe something to do with like endothelial leak and stuff like that.
Right.
Ultimately, I actually think the authors did a good job of kind of hypothesizing a little bit, but not going too far with saying this is what we think it's doing. Because a lot of this stuff we try to explain the physiology with a lot of hand waving, and it gets really close to just jazz hands. And I like this kind of EBM stuff where kids with low albumin did worse, kids with higher albumin or normal albumin did better. We don't really know why or how, but it's just kind of pure numbers here.
Sure. Just being a gen adult doctor and not having really very little, if any, clinical experience with that, I was wondering kind of where the hypothesis came from, what made them think to look at this particular variable.
Yeah.
And they say it's a multifunctional serum protein that drives colloidal osmotic pressure, binds important biological compounds, and has antioxidant activity, which all sounded really good to me, but it still didn't quite explain. And they say low serum albumin is associated with higher mortality risk in children. The mechanism remains unclear.
Right, exactly. And I think figure 1 shows it really well. You've got the curve of albumins in basically in most of the kids who didn't have any inpatient apnea. And it's just a nice little bell curve centered right around the normal number. And then the bottom part of the graph, the histogram there shows the kids with inpatient apnea and where their albumin levels were. Of course, the authors point out this isn't perfectly predictive in any way.
Right.
Is 0.5, where the numbers? 94% of the kids with low albumin still did fine. 0.5% of the kids with high albumin, still had apnea. Like, it's not a perfect differentiator, but I think, especially in some of the edge cases, I don't know if this is ready for prime time, but it's promising. It seems promising going forward.
So that's what I was going to say. This is not a message to screen infants with suspected bronchiolitis for albumin, but if one were to be ordering that panel and saw a low albumin, you'd know the kid is sick, which you probably would anyways by low serum protein or albumin, and kind of pay a little bit more attention and make sure you weren't discharging carelessly or anything like that.
Right. Yeah, and it's interesting too. One of the other things that shook out from this, and the authors noted, was also in some prior research too, is that RSV bronchiolitis was not specifically at a higher risk for apnea. I think there used to be some thought that the kids who had RSV bronchiolitis did worse. They were more likely to have apnea, but it's just the bronchiolitis in general, not the RSV, which is interesting. Other things that were risk factors were younger age in general, preterm birth. They did 32 to 37 weeks, or just lower weight for age. So basically, which kind of speaks to maybe some sort of either are these kids somehow malnourished, have a malnourishment of chronic disease of some sort, or is this just some sort of intermediate marker of there are bad things going on and
Right.
these kids are higher risk?
At risk for worse outcomes
Yeah.
in general. Okay.
Yeah, so
Great.
interesting stuff.
Yep.
Kind of on the edge between basic science and clinical translation, which is always fun. And I don't know.
Yeah, it seems closer to clinical science than basic science.
Right.
Okay.
All right. So that's our two main papers. We've
Yeah.
got a couple other
What's
ones
the
to talk
rundown
through. We got a rundown. So first off, so there's a number of states that are implementing work requirements for Medicaid. Kentucky is one such state, and these authors use some database data in Kentucky to try to see basically what was going on with that, what that means. Some of the context is there's about 1.4 million people in Kentucky who have Medicaid. There are about 330,000 people who were covered by this Medicaid waiver who are potentially eligible for work requirements. About 100,000 of them already fulfilled work requirements for other programs, so temporary aid for needy families or SNAP, the food stamps welfare programs. There were some other exemptions, so 24,000 people were students, 63,000 were caregivers or dependents, so they're already out. Leaves about 40% of that 330,000 left. Another 25,000 are probably exempted because they're frail. Another 58,000 are probably meet the requirement because they're working already. So leaving about 48,000 people, or 3.5% of the Medicaid population, who potentially at risk for
lose their
losing
coverage
Medicaid for this. Yeah. And then there's some other stuff like how many people would count for meeting the requirements for trying to find work, or would they actually meet the requirements, the criteria for frailty, even if they were frail, or were they working but not working enough? There's a lot of that. A lot of it comes down to, is trying to, there's a lot of, I think, hand-wringing in certain corners about trying to find the deserving versus undeserving poor for benefits.
Right. I was going to ask you about that. This is a politically hot topic here. I mean, it's moved off the front pages. So this study is really just characterizing the population at risk for losing coverage. That was the punchline. Got it. I wasn't sure whether it was describing those beneficiaries who might have actually lost coverage and outcomes.
No, there's no outcomes. The commentary put it really well, where they didn't describe the beneficiaries who would lose coverage. They described people who wouldn't lose coverage. It was kind of a negative. So people who aren't too young, who aren't too old, who aren't working or in school, things like that.
Right.
I think ultimately it comes down to is trying to cut 3.5% of people off Medicaid worth basically all the red tape, all the bureaucracy, all the additional stigma, et cetera. How much cost, effort, hassle, how many babies are going to get thrown out with the bathwater to try to figure out if somebody does or does not deserve state benefits.
Right. Well, it's a way for, on the upside, for states to manage expenditures. And on the downside, if you are politically minded, for governments who are against expanding benefits to kind of find, as you say, undeserving, vulnerable populations.
Yeah. But a lot of the question, even if it's strictly going to save money by not giving people benefits, there's a huge expense in trying to get people trying to figure out who's qualified and not qualified.
Okay.
So which is kind of funny because basically the idea is we shouldn't have this big government doing stuff. So let's make this big government apparatus to do this bureaucracy to figure it out. And ultimately, I think it's pretty hard to figure out if you're, who's deserving and undeserving. And it's, again, babies in bathwater here.
Enough said. Check out the paper on our website, JAMAnetworkOpen.com, last week's release.
All right. Next up is not politically charged at all, but they looked at rates of cannabis use in pregnant women in California.
That is, yes, right. Not politically charged.
Exactly. So they used the Kaiser Permanente North California data from 2009 to 2017, looked at 370,000 pregnancies among 280,000 women, because many women have more than one pregnancy. Basically, did all sorts of descriptions of what type of how frequently they use marijuana. Basically, the punchline is there was an increase from 7% to 12.5% of women who had used marijuana in the year before they were pregnant, and an increase from 2% to 3.4% of women who were using marijuana while they were pregnant over that time period. That time period has been basically where there's been a big swing in the pendulum nationally and in California as far as medical marijuana, legalization of recreational marijuana, which is coming to Illinois in January 1st.
In January 1st, right. So needless to say, but I'm going to say it or just repeat what you've said, with the loosening of restrictions on this drug in states across the United States, there are going to be more pregnant women and their babies exposed to this drug. So beginning to define that problem and beginning to understand how we as a medical establishment are going to respond to this prenatal exposure is a big task.
Yeah, and I think it's one of those things where I'm sure there are some risks to the pregnancy, but I don't know. I would imagine there's also a lot of kind of moral panic about it, and we probably have more questions than answers about what kind of risks they pose.
Absolutely.
Yeah.
More questions than answers. And,
sure.
the community has really stepped up. We've published in JAMA similar kinds of survey studies, and I think science is going to begin to answer these questions, which it couldn't as easily when it was obviously an illegal drug.
Right.
So
exactly.
we'll begin to understand what the indications are, not for marijuana in pregnancy, but for this drug in all sorts of clinical situations, and help pull the reins in, maybe, hopefully, a little bit on its indiscriminate use.
Right. Yeah, there's a lot of CBD oil out there these days.
There is. That's what I've heard.
Yeah. Next up, speaking of more questions and answers, this is a really, this is one of the studies where I don't understand a lot of it or what it means or its implications, but deep learning to assess long-term mortality from chest radiographs.
Okay.
Basically, they took the two big lung screening trials, PLCO and NLST, got like 40,000 or 42,000 patients' chest x-rays and tracked them out for years, and to teach, and had a convolutional neural network do a deep learning risk score, which is lots of words.
Yeah, it's CNN, but not the Turner's station.
Yeah, not the news network.
Correct.
And basically to predict mortality. And it turns out that just simple chest radiographs were pretty good at predicting like 10-year all-cause mortality. They divided it up into like a low, medium, high, very high risk group. And the high risk group had a mortality rate of like 53%, with an 18-to-1 difference between the risk of mortality in the highest versus the lowest, based on just, computer learn how to do x-rays.
Right. So I get that. But is it normal, not normal on the left side, or is it like hyperinflation, COPD mortality, nodules, lung cancer mortality?
I think all those elements went into the calculation, but it wasn't individualized to that degree from what I remember. But again, a lot of this is over my head. Honestly, this is one of those things where, the first time I heard about this study, it was like, wait, like this just seems like garbage. Wait, but the results, like it's actually predicting something. Like there's a pretty big discrimination. An 18-fold difference is huge.
Right. Well, so the computers, and I think we've talked about this, are really good at getting into image analysis, and they're self-learning, so that we, like the humans who kind of set them off on their path, don't exactly know what the algorithm's doing, but they learn to scan. And we have a wonderful video that our video team put together explaining convolutional neural networks and how they work, the basic concepts, on our JAMAnetwork.com website. And so they basically are able to tell what's normal from what's not normal. So if this is something abnormal, you're at higher risk for an adverse outcome, it's actually not that surprising. But what's great is the ability to do that at scale across tens of thousands and possibly millions of images. It's probably I didn't read this closely, but it seems like a proof of concept study, not one for clinical action at this point.
Yeah, no, I mean, I'm not going to MD Calc and putting in my patient's chest x-rays and saying, hey, well, by the way, your belly pain today is fine, but you're going to die in 18 years.
You're not going to do that, yes. But,
not quite ready for prime time.
But you can upload your image and see whether your image is distantly related to somebody else's image who also uploaded theirs.
And then the Facebook app can age it by 10 years.
Exactly. Right.
All right. And that's that video that you mentioned. It's Ed Livingston, JAMA editor, talking about diabetic retinopathy for convolutional neural network. Interesting stuff if you like.
Right. It uses the images from the back of the eye to explain how CNNs work.
Yeah. All right. Interesting stuff. All right. Next up, this is a little bit of a journal inside baseball, but comparison of clinical trial changes in primary outcomes and reported intervention effect size between trial registration and publication. So basically for the last, decade and a half, clinical trials are supposed to be registered at sites like clinicaltrials.gov. Basically, the idea is that stops interested parties from manipulating their study as they get preliminary data or as things change, and kind of moving the goalposts as they find the data. They looked at a sample of studies from 2011 2015. Basically, out of the 389 trials they looked at, 1 out of 3 had a change in at least one primary outcome. Most of them were just decided to not report or completely omitted one of the primary outcomes. Of the 340 of those trials that they had data they could look at, those that had changes had on average a 16% larger effect size. So basically, no surprise when you move the goalposts, things look a little better.
Right, but I typically am not exactly sure what this was saying.
Yeah.
Because they're not going back and looking at the reasons. And, from the shenanigans in the early 2000s, I think clinical trial registration was happening. That movement was happening already, but was kind of brought to a frothy peak with the Vioxx controversy, where kind of some of the endpoints were allegedly changed, and people used that, I think, to really motivate this effort to kind of get people to commit in writing in a public database what their outcomes were. And so then any change has gotten a bad rap since then. It must be the result of mis or malfeasance, but that's not actually the case. Sometimes you learn in a process of conducting a clinical trial, and there's a thing called adaptive trial designs where you actually pre-specify that you're allowed to change your outcomes.
But note that pre-specification there is important.
Yeah, but so these groups don't get into that at all because they're not looking at statistical analysis plans or protocols.
Right.
And I just kind of felt like I wasn't quite sure. And they also kind of grouped hazard ratios and odds ratios and relative risks all together as the same thing. So it's a good topic, but I wasn't sure I was convinced that this diagnosed an illness any more accurately than what we think
I think this is one more patch in the quilt of learning about trial methodology and things like that. Yeah, exactly. And also some of the changes, not specific, I didn't get this from here, but in general, some changes that happens are things like the FDA changes guidelines and say, hey, you should measure this sort of outcome in this disease as opposed to that sort of outcome. It's not just drug companies doing shenanigans. Sometimes there are above board reasons to do it. But also sometimes not.
Right. By the time it gets to a journal, you want people to kind of stick with, for publication, you want people to stick with reporting what they said they were going to measure.
Yep.
Absolutely.
All right. Last up, we have another PEDS one. So assessment of diagnostic yield of non-culture infection testing on CSF in immune-competent children. So basically, there's a bunch of testing that you can do on CSF. The basic stuff we do is cell counts and cultures. There's been in the last 2 decades a lot of IgG, IgM, PCR testing for viruses, and what else? Some antigen testing, et cetera, to try to identify specific bugs, either to focus therapy or to de-escalate therapy. So what they did, they looked at CHOP, Children's Hospital of Philadelphia, 2007 to 2016. They looked at all the kids who were 6 months old to 19, excluded people who were getting immunosuppression, who had cancer, immune problems, rheumatologic problems, or who had shunts in place to really get just kind of kids who they could be pretty sure were immunocompetent. And of 4,800 LPs on 4,100 kids, a quarter of whom were under 2, 2,000 of them, so about half, had non-culture testing. And most of them had more than one test with that. There were about 227 positives, so about 11% were positive. Most of them were enterovirus PCRs, handful of things like Lyme's and HHV6 and varicella. Only 2 required interventions, basically only 2 changed management to escalate therapy. And both of those, they said, the authors said, we're pretty sure that there was clinical data that was going to guide, there's a syndrome that was saying, hey, this kid probably has measles, let's treat for measles specifically, and that you didn't necessarily, there wasn't a big change from this non-culture testing. So,
okay.
Yeah.
So these new technologies are taking us past conventional ways we think about identifying infectious diseases, and it's a whole new world. We have a whole genomics and precision health series under JAMAgenetics.com. Visit that website, and it has some kind of primers on new approaches to identifying infectious diseases, and Tony Fauci's published in JAMA on that and all.
Yeah, and it's interesting stuff, but I mean, again, I'm cynical a lot of the time, but basically this is showing that in a pretty big sample, there really wasn't any major surprises or big changes. So this stuff isn't really ready for prime time, arguably, or it's not.
At least in this patient population.
Or it's, I don't know, a lot of times, but these are also sick kids where, a lot of these kids are kids in ICUs for weeks. How much of a cost is a drop in the bucket of doing some more testing to try to focus stuff?
And speaking of infection, I think we have a comment from a viewer. It says
No.
about strongyloides. We published a case report on strongyloides superinfection in JAMA Dermatology just a few weeks ago.
Yeah. Okay, great. Well, thanks for joining us. Join us again next week. I think we're going to be Tuesday next week, probably at 2 o'clock. We'll confirm time on social media channels.
Okay.
Of course, follow us on all the usual social media channels. Read these papers and more at jamanetworkopen.com.
Yep. And the author interview portion of this broadcast will show up eventually in our podcast. So subscribe there at jamanetworkaudio.com. Browse all of the audio offerings across the JAMA network. It's great to see you, and we'll see you next time.
Great. Thanks. Take care.
Take care.